Dear friends, now today we are going to start the fourth section of our introductory video series on PLAB 2 exam, and in the fourth section we have a chapter called Approach to the History-Based Station. Now if you have come this far, I'm sure you have watched first, second and then the third section of the introductory video series on PLAB 2 exam. On the first section I explained you a little bit about the marking scheme of the PLAB 2 exam. On the second section I explained you about the orientation to the exam center, the testing venue, and on the third section I explained you about how to understand the candidate task. Now in the fourth section we are going to enter inside a cubicle and we want to know a proper approach to the history-based station. Now what exactly is the history-based station? You need to go on my third section of the video series in which I have explained what exactly is the history-based station. So let's begin the fourth section, Approach to the History-Based Station. Okay, now once your 90-second outside the cubicle reading the task is done, then you will hear a GMC bell which says to enter inside the cubicle. You can directly enter inside the cubicle, but it is always polite to knock the door at least twice. Okay, just do 2 knocking and enter inside the cubicle. But some doctors are making mistake here and they are continuously knocking the door from outside and expecting someone else to open the door from inside for them. No, that will not happen. You just knock the door twice to show that you are polite before you enter a room, and then you enter inside the room like that. Okay, then the first thing you do is to greet the examiner by saying either a good morning or good afternoon. Do not try to be extra frank with them. Just say good morning or good afternoon. If your exam is a morning session, say good morning. If your exam is an afternoon session, say good afternoon. That's pretty much understandable. Then after that, go there and be seated in a chair which is there for you. And while you sit on that chair, please smile. Okay, do not try to bring the hangover of the previous station into this station. Do not try to be angry, do not panic, do not try to be extra anxious. Just sit there with a small smile. That will develop a rapport from your body language itself. Okay, now let me show you what that means. So here, once your 90 seconds of reading the task is done, you will hear a bell and that will ask you to enter inside the room. Now as you are entering inside the room, you know you have to knock this door twice. You enter inside. Now you are a doctor and here is GMC examiner, so your identification tag and then say good morning or good afternoon to them. Okay, then after that you be seated on this chair with a smile. Now that's something you have to do before you start your clinical consultation properly. Then there is 3 things to do which we call GII, that means to greet, introduce and then identify. Okay, in the greeting part, you are actually now greeting to the role player. You say hello there or hi, or you can directly say hello there, hi as well. Okay, someone prefers saying good morning or good afternoon to them. That's also okay. Then you introduce yourself. My name is Dr. XYZ. I'm one of the junior doctor working here. Some prefer saying I'm one of the junior doctor working in this department. Some prefer saying I'm one of the junior doctor working in the A&E. Now whichever be your setting, you have to verbalize it correctly. Okay, but then if you forget promptly that you are in A&E while you are about to introduce yourself, you can just safely say I'm one of the junior doctor working here or working in this department. Okay, then identity and identification is the third part you have to do. You will say what would you like me to call you or what is your name. You can also confirm their age, no problem. But please do not say how may I address you, because this is not how a conversation in a British culture works. It will be too much informal, it will be too much inappropriate to say how may I address you. Okay, so you say what would you like me to call you, what is your name, can I also please confirm your age. That's it. Then after that, your consultation begins with asking the presenting complaint. Now there are many different ways of asking presenting complaints. Some prefer saying how can I help you, some prefer saying what brings you here today, some prefer saying what's your problem. Okay, but what I prefer is always say how can I help you, because this will be true in all different categories of PLAB 2 station. For example, if the patient is already admitted and wants to talk to you regarding some concerns he has, then what brings you here today will be inappropriate question. What brings you here today might be appropriate question in a GP setting when a patient is there for an outpatient consultation. But if the patient is there as an inpatient and then he has some concern, then asking what brings you here today will be slightly inappropriate. So always say how can I help you. We are always on the safe side. And after that there is something called golden first minute. What exactly is this golden first minute? Now this golden first minute might not be 1 minute long. It can be 30 seconds, it can be 5 seconds, it can be 15 seconds. What exactly this golden first minute is, this means please do not interrupt the patient once the patient starts speaking to you for the first time. Okay, because you are getting all the information for free, you are not paying any prices by asking them question, so you want to let that information come for free to you. So that's called golden first minute. That is when you don't interrupt the patient at all. Once you are done with the presenting complaint, then the next thing you have to do is to elaborate this presenting complaint. Okay, now the elaborating of this presenting complaint should be done by asking open-ended questions and then the closed-ended questions. We are making most of the mistake here itself. For example, when the patient is saying, doctor, I'm having pain in my tummy, when you ask, how can I help you? Then you are directly going on to the closed questions by asking, where exactly is this pain? How did this pain started, etc. You are trying to do the Socrates for that pain, but then you are directly entering into closed question, which is slightly inappropriate. This will make the patient biased. We can't get the free information from that patient. That's what we call about golden first minute. So that's why it's very important to start by asking open-ended question. Like, for example, tell me more about this pain. Okay, and it's also very important to acknowledge, because for example, if the patient says I am having a terrible pain, you don't want to ask by saying where is the pain, but rather you want to say that at least once or twice you can say, I'm very sorry to hear that, I can see that you are in quite a lot of pain, would you like me to give you painkillers, or shall we continue with our clinical consultation? Okay, or you can just say that I understand you are in quite a lot of pain, let me ask you a couple of questions so that I'll be in a better position to address your concern. Is that okay with you? Okay, so just do an acknowledgement and then start asking the open question, tell me more about this. Okay, now whenever patients start to speak, that is where this golden first minute rule also comes, and you don't want to interrupt that patient because all the information are coming for you for free. Then after that, the patient might say, doctor, I have a pain that's on my belly button and it's also causing me a little bit of a nausea. I have vomited twice and I'm also having a little bit of a fever. Okay, now the patient's answering this much of question in the open-ended question. Now you know that since this complaint is painful one, you have to do a Socrates, which is site, onset, character, radiation, associated symptoms, timing, aggravating, relieving factors, and severity. But then this patient has already told something about site. It's in the belly button. So we are asking filtered closed question. You want to not ask now about the site, but rather ask about the onset. How did it start? Okay, and when did it start? Were you doing anything in particular when it started? These are the questions you can ask on the onset. On the character part, you can ask, can you please describe your pain for me? And then the radiation part, you can ask, where does the pain go? And sometime when the pain is in the lower part of the tummy, that is generally the case when the pain is coming from somewhere else into the lower part. So we will also ask one important question, was the pain always there when it started? Okay, that's about radiation. We prefer asking associated symptoms at last because we generally want to elaborate pain much better way in the beginning half. Okay, so then let's go into the timing part. On the timing part, you want to ask, is your pain continuous or it comes and goes? Okay, if the patient says the pain is continuous, then move into the next question. But if the patient says the pain comes and goes, then how often this pain is coming and going? And how long is this pain staying there once it comes? And is there any factors that triggers this pain each time when it comes? Okay, 3 different questions when the patient is saying that the pain is intermittent: frequency, duration, and trigger. Aggravating, relieving factors. Now the doctors here are asking, is there anything that makes this pain better or worse? Don't ask questions like that. That is what we call compound question. Compound question is strictly prohibited in PLAB 2 exam. Okay, because when you ask 2 questions at a time, the patient might answer you only one of them. Therefore, to be on the safe side, 1 question at a single time. So first you will say, is there anything that makes the pain better? And is there anything that makes the pain worse? Okay, then after that, you will ask about the severity. On the scale of 1 to 10, 1 being not so bad pain and 10 being one of the most severe pain you've ever had, how would you rate this pain? Or can you please score the pain for me? So that's how you ask the severity. Okay, and the final question is about associated symptoms. You want to ask, is there anything else apart from this? Okay, so that's how you elaborate the painful complaint. Okay, whenever the complaint is painful, you do the Socrates. If the complaint is not painful, for example, I have a heart racing, I have a dizziness, then in such case in which the complaint is not painful, you do the Odipara. Okay, onset, duration, intensity, progression, aggravating, relieving factors, and associated symptoms. For the non-painful complaint, when did it start? How did it start? Has it changed since it started? Is there anything that's making it worse? Is there anything that's making it better? And is there anything else? Okay, so Odipara for known painful complaint. And finally, there are another set of complaints which are like loss of consciousness, fainting and seizure. In such case, we want to elaborate such complaint by doing before, during and after questionnaire. For example, if the patient says, "Doctor, my son had a fit," then you can't say Socrates or Odipara is the way to elaborate this kind of complaint, but you rather want to ask, "Can you please take me to the event once again? Can you please tell me what exactly happened before that fit? And then what exactly happened during the fit and what exactly happened after the fit?" You also want to ask some closed questions on that part in order to rule out few important differential diagnoses, because that's quite important there as well. So that's how you ask the filtered closed questions. Whichever is not answered in open question, whichever is not answered when you ask "tell me more," that part you will elaborate by asking closed questions. If the complaint is painful, do Socrates. If the complaint is non-painful, do Odipara. And if the complaint is like loss of consciousness, fainting and seizure, ask before, during and after questions. Okay, now after you are done with elaboration of the presenting complaint, the last question you will ask is there anything else apart from that? Now whatever is the answer for that anything else, that are your other symptoms, and you have to elaborate that other symptoms as well. For example, the patient says, "I'm having a terrible headache," that's your presenting complaint, but at the end, after you ask open and closed-ended questions, you will ask last question, is there anything else apart from this headache? Then he will say, "Doctor, I'm also having a little bit of a nausea." Okay, then what you do is you elaborate that symptom by using some open-ended questions and the closed-ended questions as well. In the open-ended question, you'll ask, "Tell me more about this nausea." Okay, and on the closed-ended question, you ask, "How did it start and has it changed?" Okay, so open-ended question and onset and progression of that particular complaint. That's 3 questions you'll ask in other symptoms. Now some might argue that we can do the whole Socrates Odipara or before, during and after for that other symptom as well, but then we have a limited time in PLAB 2 exam. Okay, therefore for other symptoms, for all the symptoms which are not presenting complaint, we always want to ask only 3 questions, open-ended questions and question on onset and progression. That's it. Okay, then after that, once you are done with that, you'll again ask, is there anything else apart from this? And if the patient says something else, then again do the open and the closed questions on that part as well to elaborate those symptoms. Okay, then at the end of that, again ask anything else, and if the patient says no, then you only go on to ask your red flag symptoms. That's what we call ruling out the red flag with proper signposting. Okay, now what is proper signposting before you rule out the red flag? And is the proper signposting before ruling out the red flag absolutely necessary? I would say yes. You want to do a proper signposting because you want to make a role player prepared now that we are going to ask very important questions, and he will be more attentive on that part. But at the same time, you are also doing a proper signposting because you want to give an impression to the examiner that, see, now I am going to rule out red flag before I am asking other questions, because this way I want to rule out more important symptoms or more important diagnosis first, and thus I am a safe junior doctor. So you are giving that impression of being a safe junior doctor, and therefore you are also doing a proper signposting. So the signposting will help in 2 different ways. One, it will prepare your role player, and other, you will also give the proper impression to the examiner that you are a safe junior doctor. So what kind of signposting you can do? You can say, well, Mr. John, when it comes to the headache like you've described, there are always a set of questions that we would like to ask just to make sure that everything is okay. Okay, and that is the proper signposting. Then after that, you will do the red flag questioning. Now most of the time I'm always getting this question, that what are these red flag symptoms, or how to ask these red flag questions. For that, there is a technique. What you do is you go to a website called gponline.com. It's a UK based website, gponline.com. Okay, now once you are there, you put your symptom. For example, if you want to ask the red flag symptoms for back pain, then write back pain, okay, and search. The result comes red flag symptoms of back pain. Just you click on there, and then you have got a set of symptoms which are specifically for back pain, and they are red flags. Okay, so this way we can collect the red flag symptoms of different kinds of complaints that you'll ask here. Then once you are done with that, if you want to ask other questions to rule out other differential diagnoses, you can do it here. Now once you are done with this, you will ask past medical history. Now since you are changing the topic from history of presenting illness to the history of past illness, you want to do a signposting. Okay, for the signposting you can say, well, Mr. John, now I'd like to ask few more questions regarding your background health in general. Or you can say, well, Mr. John, now I'm going to ask few set of questions to get more insight into your background health. Or you can say, Mr. John, now I want to ask few questions regarding your past health in general. Okay, that is the signposting for past medical history, and then you start asking questions. These are few important questions you have to ask in past medical history. Has this happened before? How has your recent health been apart from this? Have you been diagnosed with any medical illness? And if there is any closed question, you can still ask, by any chance, any high blood pressure, any diabetes? Are you under any medication? And if you want to ask closed question, you can also ask, are you under, by any chance, any medications like steroids or long-term antibiotics? Do you have allergies to anything? And then you want to ask surgical histories or instrumentation history. So is there any history of surgery in the past or any instrumentation? And then finally, are your family members suffering from any medical related problems? Are the questions that you want to ask on the past medical history. Then you are entering into the personal history. You want to do a proper signposting here as well. So what you will say, well, Mr. John, now I want to ask few questions regarding your lifestyle. Or you can put on more context and you can say, well, Mr. John, when the people complains of headache like yours, there are always some set of questions that are on their lifestyle which is necessary to ask, or that might be relevant here. Okay, you do a signposting and then you start asking, do you smoke? And if yes, then what do you smoke and how much do you smoke? Do you drink? If yes, then what do you drink and how much you drink? Then you ask about his diet. Just ask, tell me more about your diet, tell me more about your physical activity. And if the station is appropriate, not in all situations, but in the appropriate situation, you want to ask about sexual history as well. Okay, are you sexually active? Do you have a stable partner? By any chance, any other partner apart from that? Do you practice safe sex? When was the last time when you practiced unprotected sex? Are the question you can ask on the sexual history. Then recreational drugs. Mr. John, when people are having this kind of problems, they might turn into things which they think might help them cope with. For example, recreational drugs. I'm just wondering if you do any of these. Okay, you are asking recreational drugs in a non-accusatory way. Then you'll ask social history, like who do you live with? Okay, what do you do for your living? Have you traveled recently anywhere? Okay, and that's your social history. And this is more important in the station which is related with cancer. Okay, because you want to know what kind of support he has when you go back home. Finally, there is a plus minus ICE questioning. Now, what is ICE questioning? The ICE questioning is the question on the ideas, concerns, and expectation. Okay, before a patient comes to you, he might have a lot of things going on his head, and the only way to enter inside his head by asking ICE questioning. Okay, now I'm keeping here plus minus because I don't want to ask ICE question when the situation is very, very emergency. If the patient is saying that I'm having a central chest pain that's going on my left jaw that is causing me a shortness of breath, that's like a heavy crushing sensation, then you don't want to ask, do you have any idea regarding what might be causing this chest pain? Okay, the situation will be inappropriate in such case. But in other case, for example, especially in the patient presenting to the GP, you can ask ICE questionings. Okay, you can ask questions like, for example, if the patient says I'm having a tummy pain, you will say, well, when it comes to the tummy pain, there are a lot of different causes. I'm just wondering if you have given any thought regarding what might be going on with yourself. Question and ideas, question and concern. Is there anything in particular that's on back of your mind that's worrying you? And then question and expectation. Are you hoping anything out of this consultation? Are you expecting anything in particular out of this consultation? Or do you think we can do anything in particular to help you in this period of time? Or questions on expectation. Okay, so you can ask ICE questioning on such situation. Then you thank the patient. You will say, thank you for answering all my question, and then go on to your further part of the clinical consultation. Now, since this is a history-based station, you will not actually perform any examination, but you have to verbalize what are the examination that you want to do. Okay, that's very important. Most of the doctors are thinking this is just a history-based session. I'll not tell what are the examinations that I want to perform. And that's a biggest mistake. Even if it is not an examination-based session, you have to verbalize it because there is some mark for that. That is one of the important skill area in a clinical consultation of a PLAB 2 exam. Okay, now since this is a history-based session, you will verbalize it. You will say at this point of time, it will be sensible to offer you some examination. Or you can say, let me tell our plan for you, would like to examine you. And then you will say what are the examinations that you want to perform. For example, if you want to perform vitals, which is of course the case in most of the scenario, you will say, I'd like to check your vitals, which includes checking your temperature, heart rate, breathing rate, oxygen saturation, and blood pressure. If you want to do a general physical assessment, which is generally often the case in all scenarios, then you will say, I'd like to do a general assessment from your head to toe. And then if you want to examine his Chest, you will say, I'd like to then do the focused examination of your chest, your tummy, or also the examination to check the function of your brain and nerves if you want to do the cranial nerve examination. Okay, so this is how you verbalize the examination. The examiner will say, well, doctor, all the examinations are normal, please proceed. Or examiner might say, vitals has this problem, and the chest has this kind of problem. The examiner will give you some findings. Just pause for 1 to 2 seconds for examiner to interrupt you. Okay, then after that, you will say, well, then I would also like to run some initial investigation, or you can say, I'd like to run some initial test, which includes some routine blood test, some routine urine test, and some routine stool test, if required, wherever appropriate. Okay. Or you can say, I'd like to run some imaging studies like an X-ray. Okay, but for advanced imaging like CT and MRI, for special investigation, you involve your senior, it will be much more safe. Okay, now once you are done with that, examiner might say on the initial investigation, these are finding, or examiner might say reports are awaited, move forward. Then you have to disclose the diagnosis. Okay, now this diagnosis is your provisional diagnosis. Okay, most of the time in the PLAB 2, the scenario are so much classical that you are easily able to make a provisional diagnosis. Okay, but in some case in which the scenario are vague, the examiner will interrupt you and say you that, doctor, what are the differential diagnoses that you have thought? Okay, but most of the time examiner might not interrupt you, and you will have a very classical case in which you have to make a historical diagnosis, a provisional diagnosis. So you will say, Mr. John, so far from whatever you have told and from whatever we have done, or you can say, Mr. John, based on our assessment, I think you are having a problem called giant cell arteritis. I think you are having a condition called giant cell arteritis. Don't say, I think you are suffering from giant cell arteritis. Don't say you are suffering from pneumonia. Don't use that word suffering. You say, we are suspecting a condition called pneumonia. Okay, then you pause. In this pause, you will check the patient reaction. Do not directly jump into the explanation. You pause for a while, check the patient's reaction, and ask his knowledge on disease. Have you known about that? Have you heard about it before? Would you like me to explain it? And then you explain it. Whenever I take one-on-one mock with different candidates, I often find that they are struggling in the part when they have to explain a disease to a patient. This is, of course, an important skill to master, and if you can explain nicely a medical disease to a patient, then half of your job in the management is done. Why candidates are not able to explain a disease to a patient? It's because they are trying to explain the disease like the way it is explained in the textbook. As a result, they tend to speak a lot of medical jargons, and the patient will not understand what exactly you are trying to say. So this is an important skill to master, and there is a format for that. Number 1, first of all, explain the physiology. Then after, explain the pathology, and finally explain the symptomatology. This is the way you explain the disease in most of the time. Physiology, pathology, and symptomatology. Now don't try to explain whole lot of physiology, just try to explain what happens normally, then what is happening in your case, and then list out few symptoms of that disease. Don't list out all the symptoms that's in the textbook, only list those important symptoms which he is showing so that it makes sense to him. For example, you are consulting a case in which a patient is there, a young patient is there, who had type 1 diabetes mellitus, presenting with tiredness in ED, along with the symptoms of nausea and vomiting, and then you go on to examine him and you go on to run some tests. You find that the blood sugar is high and there is acidosis in the ABG, and you can also find ketosis. So you know that this is a case of a diabetic ketoacidosis. But you ask the patient, do you know what does that mean? Would you like me to explain? And the patient says, yes, doctor, please explain it to me. And I often find many candidates are not able to exactly explain in a way where there is a less medical jargon and explain in a way that makes the sense to the patient. So let's take this as an example and let's try to explain this disease. First of all, physiology, pathology, symptomatology. So you'll say, Mr. John, normally when sugar level in the blood goes high, there is a gland called pancreas in our body which releases insulin. This pushes the sugar into the blood cells for storage and energy. In your case, you have type 1 diabetes mellitus, which means pancreas don't make enough insulin and thus cells start starving for glucose. Now, this leads the body to break down fat for energy as an alternative source. This leads to the increase in a level of a chemical called ketones, which due to its acidic nature causes a lot of symptoms as you have described, like tiredness, feeling sick, and sometimes breathing can be affected. If not treated on time, it can also be potentially life-threatening. Okay, now that you have explained the diagnosis, you have to formulate a plan. Now the plan can be different thing. For example, if still the diagnosis has not been confirmed, then you will say I'd also like to run some special test after discussing with my senior, or you will say I will make a senior review, or you will say I'll refer you to the specialist where they will perform some special investigation to confirm the diagnosis. Then, according to the situation, you might need to observe this patient for a while, or you might need to keep this patient in the hospital, or you want to send this patient to somewhere else. Okay, so this is your plan, also coming under your plan. Then after that, you will say for the treatment, we'll give you the medication if that is relevant, and the treatment will always start with a symptomatic relief. For example, if the patient is having pain, don't give the definitive management, but first of all, manage his pain symptomatically and then give the definitive management. Okay, now after you formulate your plan, then it's very important to seek the agreement of the patient. For example, if you want to keep the patient in the hospital, you seek agreement. Are you happy with that? Okay, are you happy to try that if there is any medication involved? Then you have to also do a safety netting. Safety netting are those symptoms which you are giving to the patient and telling them when to seek medical advice back again. Okay, if the patient is being discharged or if the patient is being sent back to home, then you give the follow-up advice when to return. Okay, and finally you conclude the station by saying, is there anything else that you would like me to answer? Okay, and this way you give the holistic plan. Now sometimes what happens is in the management part, the doctors are struggling a lot because they are just doing a one-way communication, because the reasons are understandable. They have a very limited time on the management part, they have done a poor time management, and on the little bit of amount of time whichever is remaining, they want to explain everything, and that's why they are getting very less mark in the management. That's why you always give an option to the patient and ask what part the patient wants to learn more, and you explain that part only. For example, you will say, well, now we have to keep you in the hospital, then we need to do the special investigation, then after we confirm the diagnosis, we need to treat you, and after you are okay with that, we'll send you back home with some advices. Okay, then after that, if the time is very less, then you can say, which one would you like me to discuss first? Then the patient is concerned about medication, discuss about medication, don't talk about a special investigation, discuss about other things. So that is a small trick when the time is very less, but otherwise you have to do everything. You have to formulate your plan, you have to seek the agreement, you have to do the safety netting, follow-up advice, and conclude the station. Okay, this was one small piece of video on history based station. We have discussed how to approach the history based station. Few more approach in few other stations will be coming up. Please subscribe the channel and support me so that I will be encouraged to record even more videos on PLAB 2. Hope that helps.